speakers. You will briefly hear music while I transfer you to the main conference. I will begin the introduction and turn the call over to Dr. Renee Turchi. Please be aware that during the transfer and introduction, your line is open and anything you say will be heard in the main conference. Please hold. Good afternoon. My name is Joanna, and I will be your conference operator for today. At this time, I would like to welcome everyone to the new DHS Psychotropic Drug Guidelines and Behavioral Health Phone Consultation. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, you may please simply press star, then the number 1 on your telephone keypad. And if you would like to withdraw your question, you may please press the pound key. Thank you. Dr. Renee Turchi, you may begin your conference.
Thank you very much. Welcome, everyone. I wanted to thank all of our Pennsylvania Medical Home Program team members for making this webinar happen, as well as our guest speakers in the PA chapter of American Academy of Pediatrics. So welcome. This is the new Department of Human Services Psychotropic Drug Guidelines and Behavioral Health Phone Consultation webinar. So we're really excited. This is hot off the press information. I want to get right into letting our speakers talk about this important topic. I wanted to just briefly introduce our speakers today. We have 3 speakers. First, we have Dr. David Kelly, a friend of the Academy and of Pediatricians, who is the Chief Medical Officer for the Pennsylvania Department of Human Services Office of Medical Assistance Programs. And there he oversees quality and clinical aspects of the medical assistance programs that actually serves over 2.5 million recipients across the Commonwealth. Dr. Kelly has practiced medicine. He has worked for Aetna Health in the past, and he has been a staunch supporter of children's issues, and really we're indebted to him and all the advocacy that he does for children and adults in Pennsylvania. We also have Dr. Della Dare, who is the Medical Director and Chief Psychiatric Officer for the Pennsylvania Department of Human Services Office of Mental Health and Substance Abuse Services, or OMSAS. Dr. Adair trained at Pitt and Temple, and also at Western Psych Institute, and has completed some work in geriatric psychiatry. Excuse me. Dr. Adair has consulted on many initiatives, including the state immunization model, the Governor's Council on Veteran Services, and has been on various advisory committees related to opioid addiction. And he's also on CMS, consults on CMS's hospital standards. So we're thrilled to have Dr. Adair with us as well. And last but not least, Dr. Lizette Ramos, who was raised in active duty military family and graduated from University of Miami, and also attended Mount Sinai School of Medicine in New York. She completed pediatric residency training at Einstein in New York, and has done some work in community access and received an award to look at community access to child health resident funds. She's board certified in pediatrics and general psychiatry and child and adolescent psychiatry, so triple boarded. And she's a member of multiple committees, as well as the American Academy of Child and Adolescent Psychiatry and the Academy's Committee on Child Maltreatment and Violence. So we're thrilled to have all 3 of you here today. Thank you for being willing to do this webinar. And with that, I will turn it over to my colleagues.
Hi, good afternoon. This is Dr. Kelly with Department of Human Services. It's great to be here. I am an internist geriatrician, but I think in the past the Academy's made me an honorary pediatrician. So if you ask me too many technical questions, I will definitely defer to other colleagues. So we really want to take the opportunity to provide really an overview of the department's focus on psychotropic use psychotropic medication use specifically in children. And I think Dr. Adair always has great humor, and I think we threw this cartoon in just to make sure that people are paying attention to the fact that sometimes everyone has a unique problem, and we need to think in terms of patient care that is unique to our circumstances. So I appreciate Dr. Adair's cartoon. Third slide really kind of gives some of the background as to why the department took on this issue or thinks this issue is important. We actually had the folks at CHOP, the policy lab at Children's Hospital in Philadelphia. We gave them a lot of our Medicaid-related data, and they did an independent study that really found that there were significant challenges in looking at psychotropic use, and I'm not going to read each of these results here, but what we found was that there really seemed to be a lot of psychotropic use and antipsychotic use, specifically, especially in kids in foster care, and we know that these children are very complex, have very complex needs. We also found that many of these kids in antipsychotics had an ADHD diagnosis, and that there was a lot of polypharmacy going on. And happily, I think that in the department, we really have been looking at this. I've been with the department 11 years, and I think we started to look at this probably 9 years ago or so, and we really started to focus especially on those younger children, and I think we've seen some results of that focus in that there are much lower rates of psychotropic medication use and polypharmacy in that younger age band, in the 3 to 5. The department always is looking for recommendations, and I will say that these recommendations came not just from the Policy Lab's report, but there were a whole host of stakeholders that were involved in this whole process, including patients, including adults now that had gone through the foster care system. We also included our managed care plans. We included the judiciary system. So there were a whole host of stakeholders that were engaged over probably a 3-year period of time. And the Policy Lab really kind of consolidated a lot of those recommendations. And maybe Dr. Adair, maybe you could go through some of the basic recommendations here.
So, and hi, Dale Adair. So the, as Dr. Kelly has pointed out, this has kind of been a concerted effort that has occurred over a fairly long period of time, and there were a number of different entities, agencies, advocates, and stakeholders involved in a variety of work groups to look at these issues. But a couple of the kind of recurring themes were around the fact that the plans had that their prior authorizations were not consistent. So if you were treating a child who had one plan, and then you had another child in your practice that was covered by a different plan, that the requirements for the prior authorizations, just weren't consistent. So one of the things that the department has worked on is working with the physical health plans so that their prior authorization criteria are consistent and consistent with the Pennsylvania's fee-for-service prior authorization requirements. And I believe now that that all of the physical health managed care organizations have moved in that direction. The other was around the use of other treatment modalities, of other interventions. So, from a behavioral health standpoint, as a psychiatrist, and I am not a child psychiatrist, but what I'm about to say actually is true, I think, for basically all ages, and that's that medications are always just part of the equation when we treat someone with mental health concerns. So what we want to make sure is that an individual who may require medications, that they also have access to the other treatments, whether that is particularly for kids in foster care or any other child who has been subject to trauma, that they receive the necessary treatment for their trauma to help them recover. So, so that's one of the areas that we have been stressing and are currently working with our partners within the Office of Children, Youth, and Families to make sure that that trauma-informed care is out there. And then third recommendation, this actually is a recommendation that is a federal requirement that all states have oversight over the use of psychotropic medication. So it's, this has been a national concern, and the department with the agencies of Office of Medical Assistance, the Office of Mental Health, Substance Abuse Services, and the Office of Child, Youth, and Families have been working together on this, on these important issues that I believe a lot of you are definitely very interested in trying to move this forward, ensuring that the kids that are under your care receive the best care possible. For us, it really is about assuring that kids get the appropriate care. So one of the things we have been clear not to say is that that no kid should be treated with no medication, because obviously that is would not be considered good practice, but that in whatever circumstance that people receive the appropriate care for whatever they're struggling with. And for a lot of these kids, what we have found from speaking to graduates of the foster care system is that a lot of it had to do with trauma, and medications aren't really are necessarily the appropriate treatment for trauma. There may be some symptomatology that comes about as a result of that trauma that may require some limited use of medications, but that there are other forms of treatment that are probably more appropriate and that should be utilized. So so we had all these all these work groups, the recommendations, and then what we sat down and worked over with our work groups was what should be our approach and how do we have a meaningful impact. And some of those I'm sure you have seen with the release of the psychotropic medication prescribing guidelines, and there were members of your organization, including including Dr. Ramos, who were instrumental in helping us pull those together and to get those out. Those guidelines, which there will eventually be some further discussion in probably a webinar to go in more detail on those guidelines, but they really are part of the part of our response and what we tend to refer to as another tool in the toolbox to hopefully help everyone. One of the very exciting things is the telephonic psychiatric consultation service, which is being called TIPS, that we hope to have rolled out in within the next couple months. But this will be an opportunity that is based on the Massachusetts model that has actually spread to other states. And so, we have been working with Dr. Strauss from Massachusetts to help us really understand what they did and then kind of put it in context for Pennsylvania. But the basic model, and Dr. Kelly can expand on it, but the basic model is that in each one of our health choices zones that we will have a service where, as the practitioner, you can call in if you have a child that is challenging from a behavioral health standpoint. Maybe they were hospitalized or whatever. They've come to you, they're on medications, and you want to get some input, some advice on what to do with these medications. This service will present that opportunity for you, where you'll be able to call in, and once you call in, that you would get a response back from a behavioral health person. Now, those teams are going to consist of child and adolescent psychiatrists, a behavioral health specialist, which will be either a licensed social worker or a licensed psychologist, clinical psychologist, and a care management person that then will help to kind of coordinate things if that child needs further services within the behavioral health realm. So they'll be helping to coordinate that as well. But the really key part of that, at least for me, is that you'll be able to call in and be able to consult with a specialist who will be there to provide help for you in those challenging cases. So, that's one of the things that we are really, really excited about. I don't know, Dave, you want to say anything further about that?
Again, likewise, we're very excited about this program. It has been successful in multiple other states where it's been evaluated. Providers tend to be highly satisfied with these types of services. And really, this is another aid, hopefully, that makes your practice of pediatric medicine easier. At your fingertips, you really have an expert that is well versed in treating some of these very simple but also complex behavioral health conditions. And again, we just want to be very clear that this consultation line, it's a peer-to-peer consultation line, and it really is meant for kids with any type of behavioral health condition. It's not just focused on kids that are on an antipsychotic or on 4 or more medications, but it's really meant to be highly utilized by pediatricians with concerns, a whole range of concerns around behavioral health treatment. We're also hoping that this program facilitates coordination of care, Because part of what the TIPS team is going to help do is to hopefully help to also coordinate care if that child needs to have further behavioral health intervention. They'll be working with both our physical health and behavioral health plans to really coordinate better care so that children get the non-pharmacologic treatments that Dr. Adair alluded to earlier. So we're very excited about the program where we put out, actually our managed care plans are going through a proposal process, and we've had multiple vendors apply in each of our health choices zones. So we're very excited, and hopefully we'll be rolling that program out over the next several months once those vendors are chosen. There will be, in theory at least, there will be one vendor per health choices zone. Some vendors want to actually provide the service across several health choices zones. So once we make those final determinations, we'll obviously be communicating back to providers. We also, part of the vendor's responsibility is that they will be required to come out and visit our high-volume Medicaid child-serving practices to introduce the program so you know who they are, who you're talking to, so that there's that comfort level that you have that you're dealing with experts that understand the situations. They also understand that these aren't providers calling from California or Oregon. These are providers that are really here in Pennsylvania. So,
Dave, I guess one of the things that we probably should say about this, and you alluded to it, but I don't think we clearly said it, and I bring this up because it came up at a meeting I was at yesterday. The TIPS program really is geared so that any practitioner treating these kids could call in. So primarily our expectations is that it would be from the primary care arena, the pediatricians, et cetera, but there is also the possibility that an adult psychiatrist who is treating a child could also call in and utilize this consultation. But the consultation, because these are MA dollars, the kids really are kids covered by MA. Hopefully at some point we would be able to get the commercial insurances on board because we would love if we were able to do it for all kids. But currently it is for MA covered kids. And then, we've spoken previously about the prior authorization of the antipsychotics, which will be up to age 18 for all of the plans. But the other big part of this that I think is also exciting is the dashboard that we will be rolling out soon. And this dashboard has red flags, if you would, that will signal the managed care plans, both the physical health plans as well as behavioral health plans, and the child and youth county offices, their caseworkers. And it's really geared, in our mind, to really, if a child has, I alluded to before the fact that, a child receiving other treatments besides medications. So if Dale Adair is a child who is on psychotropic medication and has not seen has not had a behavioral health appointment, then one of the things that we will actually be requiring of the plans as well as the case worker from Child and Youth Services, is that this would start a conversation so that we can, again, assure that the kid is getting whatever appropriate care that they need. So the dashboard is currently being rolled out and should. We're actually waiting for some information from some of the. We're actually going to send it initially to 8 target counties of Child and Youth Services to begin to work with it. And we're waiting for some information back from all of them before it actually goes out. But the dashboard is pretty much set, although it is as most things are, kind of an evolving process. So as we learn more, the dashboard itself will probably undergo some modifications. But I can tell you that a lot of counties are very excited about being able to look at data about kids that currently the information they don't have. So, Dave, you want to say anything else about that?
Yeah, sure. There's really 2 dashboards that we're going to be doing. One is our Secretary Dallas, wants us to post on our website kind of a global dashboard that looks at all kids in Medicaid and looks at kind of who's been treated or what % has received ongoing treatment with an antipsychotic. And we've been trending these types of things for, as I said earlier, probably 7 or 8 years or longer. So we'll be continuing to trend that, and the current secretary, he wants to actually post that online so that that's publicly available. Again, that will look at the Medicaid population in general for kids. There also will be a kind of a separate dashboard for looking at the same parameters of kids in foster care. So there's that dashboard that'll be posted out to our website later this year. And then there's this other dashboard that we've developed that Dale's been talking about it's an internal, very detailed, member-focused, individual patient-focused dashboard that we actually send to our physical health plan, our behavioral health plan, as well as the particular county children and youth agency. So the whole idea is to share that information so that all of those entities start to have discussions with you as providers about whether or not is there a need for ongoing treatment with, let's say, an antipsychotic medication. We're even more focused, though, on really the behavioral health component and have these kids gotten their comprehensive non-pharmacologic interventions. So we're very excited about that. As Dale said, we're going to pilot it with 8 counties. We're hoping to get that off the ground this month. And then our plan really is to do that across all 67 counties. We will then be sharing that information with our MCOs and the counties on a quarterly basis. So we'll be refreshing that data and we'll be kind of tracking outcomes. We'll also, down the road, once we get the TIPS program up and running, we envision being able to really track any kids that perhaps the TIPS line actually intervenes with. So we're very excited about the dashboard. Right now there's a lot of manual activity that goes on from an IT standpoint, but we're down the road hoping to automate that.
So those are the big things that we're working on. The Office of Child, Youth and Families is working on assessment tools, and we want to assure that there's consistent use of those assessment tools. And obviously, consent, the consent process has been a large part of the discussion. throughout the work groups that we've had discussing this entire topic, and there's some guidance in the prescribing guidelines that I believe went out to all of you. I want to make sure that we leave sufficient time for questions. This is our contact information, Dr. Kelly and myself, and you can always, if you have questions, can contact one or both of us. Dave and I actually end up spending quite a bit of time together. We work on a lot of projects together. Questions that you want to end up sending or as clarification to either or, we would be happy to get back to you on that. But again, we want to make sure that what we basically want to do is kind of give an overview, because there will be much more to come on this topic for all of you. But I wanted to make sure that at least as part of this call that we left enough time to answer any questions you may have. So I'm not sure how the moderators are doing the question piece.
Yeah, this is Renee. Thank you so much. There's actually a couple of questions, and I'd be happy to read those out for you guys, and then and for folks that can't see the questions, then everyone can hear them. Is that okay?
Sure. They're in the chat function?
Yeah, they are. I can read them to you quickly. Thank you so much. That was a great overview. So I just want to thank all of you for that presentation. So our first question comes from John McGee. Is the TIPS team available to all patients independent of insurer or just patients with Medicaid insurer? I think you mentioned a little bit of that, and I wonder if maybe some of that question also might include whether children who are covered by PH95, dually insured, are they eligible? So.
The short answer is it's Medicaid eligible only at this point. So the PH95s are technically Medicaid eligible. So yes, would include those kids, and many of them are either insured. There's a primary insurer, but Medicaid may be secondary. It also does include those very complex children that are also dual eligibles, Medicare and Medicaid. So those are the populations. Right now, we're using Medicaid funding. Some other states have used other unique mechanisms to fund this so that it could be opened up for all carriers. Those of you that know me know that I whatever I can get done, I try to get it done. And if I need to do it incrementally, we do it incrementally. So I can only control what happens in the Medicaid space at this point. So we know that you as physicians and practitioners, there are challenges when there's a program just for Medicaid. So we know that's sometimes a challenge, but at least we want to make the service available for our Medicaid kids.
Great. Looks like we have another question here. Our pediatricians are having, it's difficult for me to read this, are having difficulty prescribing Vyvanse. I can't quite see the question. It's like cutting me off. Does anyone know if it's
Hold on one second, Renee.
I can't read it. It's like cutting. Wait, let's see. There we go. So I'm sorry about that. Our pediatricians are having difficulty prescribing Vyvanse for patients that have Gateway Medicaid health insurance. This medication is not covered. Do you have any alternative medications you would recommend that are covered by Gateway? Us at Medical Home, we dive right in because we're advocating for our kids. So.
I would say the best thing to do is to actually contact Gateway and have that discussion with them. If it's not available, we can certainly go back and look at from a pharmacy standpoint. We approve all of our health plans prior auth policies. We can certainly go back and look at any policies that Gateway may have in place specific to that medication. I would encourage you to reach out to Gateway. Dr. Mike Madden is their medical director. He's usually fairly receptive to calls and or discussions.
Okay, great. Thank you, Dave. Let's see, we have another question here. Does this program include children covered under CHIP?
I think the short answer to that is yes.
So CHIP is included as well.
And I'll say that with a caveat in that CHIP is still a separate insurance program, and it is in the process of being moved over to the Department of Human Services. I will say that the funding stream for this is actually currently going through our Health Choices MCOs, but I would think that, and we'll have to internally discuss this, I see no reason why the service couldn't be used for kids that are covered under the CHIP program.
Okay, great. All right, next question. I'm interested in data collected. So how many diagnoses were collected? Is there any outcome data from the Massachusetts project? And how quickly can I expect a response to a prior authorization? So tell me if you want me to read those questions again. I know I kind of fired a lot at you there.
As far as the prior authorization, again, our managed care plans have guidelines in which once their information is complete, they are supposed to either give you an approval or denial. And actually for kids, prior to that denial, they are at least supposed to, by their contract, supposed to reach out to the prescribing provider. So again, that process, if it's not happening or it's not happening as efficiently as it needs to be, we certainly need to know about that. And I think because we quote unquote have tightened up some of the prior auth requirements for mainly on antipsychotic medications, our goal here is not to make that process harder. It's to make us all think about what is in the best needs of those children. And we've told our plans, we've been very clear with them that this program is not about pushing out more denials. It's about facilitating discussion about what is the best thing for that child. And that's why we put the TIPS program together. And that was the last question. And Renee, there were two others. Can you?
Yeah. How many diagnoses were collected and outcome data from the Massachusetts project?
There are outcomes that were actually reported in Health Affairs, and we can actually get that article to you, and that can be disseminated to the membership. So there also, I think there's another, I think there's a return on investment article I'm less interested in. It's the state of Wyoming, but the Massachusetts article was published recently, I'm going to say in 2015 or late 14 in Health Affairs, and we'll get that to you. It describes the program. It also describes some of the outcomes. Are we collecting diagnoses? I guess, I don't know if that question is specific to the TIPS program. We'll be collecting some basic data sets. So for instance, the vendors will be giving the department kind of a list of who are the patients that the TIPS program in which they have offered advice. And again, this is not telemedicine. This is peer-to-peer consultation. So we will be able to, I'm not so sure we're going to require that the vendors list, Susie's 10 diagnosis, medical or behavioral health or otherwise. If we collect who their Medicaid ID number is, we can actually do analyses on the back end. But we're actually working with our managed care plans right now to think in terms of an evaluation piece. And part of our discussions with Massachusetts and other states is, how do you evaluate, excuse me, the effectiveness of the program? So we're going to take some lessons learned from Massachusetts and Connecticut and some other states to really be able to assess the program.
That sounds great. We have just a couple more questions. One challenge is when a child is moved into foster care and their providers, both physical health and behavioral health, change. Their prior history and medication list is not always available to the provider at the point of service. Will the TIPS program have access to this data, or do you have any other suggestions?
We don't envision right now the TIPS person to have access to that patient's medication list. However, as I mentioned, the vendor really needs to be in communication with the physical and behavioral health plans. And both of those plans should have medication lists or have the ability to look at comprehensive recent prescription medication fill lists available. So right now we're not envisioning that with the TIPS vendor. I will say that if you as providers are interested in looking at that more comprehensive snapshot, that's certainly a discussion. I would contact that physical health plan because they're the ones who pay for those medications. And for most conditions, excluding substance use disorder treatment medications, the health plan should be able to share with you the medication lists. The dashboard that I previously mentioned that we're pushing out to the physical health plans, the behavioral health plans, and the county assistance offices, that will include a 12-month look back of the medication lists. So we're encouraging those children and youth caseworkers and the behavioral health plans and physical health plans to really, they will have in that dashboard for kids in foster care a 12-month look back of medications that have been paid for by the Medicaid program. So if you're having discussions with any three of those entities, they should have a comprehensive list.
Okay, great. We have just I know we've got about a minute or two left. I'm just going to try to there are three looming questions here, if I can try to get through them quickly, or if also we could send them out via email. It is difficult to obtain a comprehensive list of BHRS providers for CHIP. Do you have a suggestion for finding this information?
So you're looking for a list of what, I'm sorry?
BHRS, that's behavioral health, isn't that rehabilitative services?
Yeah, so
yes, specifically.
Yeah, the behavioral health managed care organization in whatever area that the clinician is in should actually be able to provide some information there.
Okay.
I will look to see, I've never had that question before. I will look to see if there's actually, on the website, there actually is the ability to locate certain treatment modalities. I don't know that specifically is on there. So that actually is a question that we can actually take back. I think the first place to start would be the Behavioral Health Managed Care Organization.
Hey, great. If you get that information, so we can send it out to the practices. There's a question about, are you going to get or have you gotten patient or parent input into the intervention and an overall patient satisfaction survey? Is that something that's incorporated?
So we haven't actually done surveys. As part of the tips, there will be some satisfaction stuff woven into that. And actually, if you look at the outcomes from Massachusetts, that's one of the things that they found very high marks on was satisfaction from the families as well as from the providers. So the PCPs up there have been very happy with the services that have been provided. That's kind of where that is right now.
Okay. Thank you. And one last question here before we wrap it up. Is there a period of time that the Medicaid HMO will pay for a psychotropic drug that requires new documentation provided with the prior authorization, lab results, BMI, EPS using the AIMS here? So,
I think the short answer to that is yes. And again, the prior authorization guidelines, and we can send out the fee-for-service guideline. We've asked, I believe all of our plans are following something that is very, very similar. And I know we had a lot of discussion in the fee-for-service world with our stakeholders in public meetings about working either with a psychiatrist or in consultation with a psychiatrist, and that there is some leeway in which those types of things, those monitoring things, can be done. And so we don't want, if someone really feels that this is appropriate treatment and not all of those monitoring things have been done and completed and results known, there is some leeway there for both, I think, initial requests and then ongoing requests. So we can share with you the fee-for-service guideline. I believe the other managed care guidelines, we had our pharmacy director actually review all of the managed care guidelines to assure that there was consistency along those areas.
Oh, that's great. And again, if you can get those to us, that would be wonderful. We're happy to send those out to the whole group, the network. I think we're just about out of time, but I want to thank all of you. This was an incredible webinar, really informative. Obviously, you can see there's a lot of interest around this issue. It's certainly a needed service for us. So we're really excited here in Pennsylvania that you guys were willing to be innovative and start this. And perhaps maybe as things get rolled out, we could even come together again as a community to talk about how things are going. So I want to thank you, our speakers, and thank everyone for participating today.
Thank you for having us.
Thank you.
Hey, take care, everyone.
Bye. Bye.
Bye-bye.